I'm Chidchanok from Thailand. I used to do fellowship training at Srinakharin University with Dr. Shalawit, and now I'm working at Noprat Ratchathani Hospital. It's my pleasure to be here to talk about the biceps and triceps insertion and their related lesions. Distal biceps tear usually occurs in the age of 40 to 60 years old, male more than female, and it has short and long heads. The external rotates 90 degrees at the musculotendinous junction level. So this makes at the insertion, the short head becomes distal to the long head, and the long head inserts on the apex of the tuberosity. This makes the short head a powerful flexor of elbow and the long head greater supination strength. Lacertas fibrosus is a stabilizer to the distal biceps tendon. Distal biceps tear in acute traumatic injury. There is a sudden forced muscle eccentric contraction. The tear commonly found on the short head of biceps. On the other hand, chronic degenerative injury usually happens after repetitive friction between the tendon and radial tuberosity, usually found on the long head of biceps. These are the predisposing factors. Symptoms would usually are pain and weakness. In physical examination, there would be tenderness, weak flexion, and supination strength. The cord-like tendon is palpable when it's partial tear or tendinopathy. It would not be palpable in complete tear, but sometimes the intact lacertus fibrosus can be mistaken as the bicep tendon. Specific tests for a complete tear are hook test, bicep squeeze test, reverse pop eye sign, and the bicep crest interval of more than 6 centimeters. In plain films, we can look for radial tuberosity abnormalities such as hypertrophy or spur. Next modality is the dynamic ultrasound. They can differentiate between the complete and partial tear. However, it's operator dependent. MRI is a good standard of investigation with more accuracy at grading the injury when it's in the flexion, abduction, supination, or in short, flaps. Later in 2022, there's this study describing a turtleneck sign can be found in a severe retracted distal biceps tendon rupture with a good intra and inter-observer reliability. The last investigation that can be done is the endoscopy, which provide direct visualization, but have to be careful with the neurovascular structures. Management depends on the percentage of the tear. Conservative treatment is usually chosen when the tear is less than 50%, but if it's more than that or fail conservative, then surgical treatment is needed. What about incomplete tear? If it's left unrepaired, there will be a loss of supination and flexion strength and endurance. So surgical treatment is recommended. There's no consensus on the standard protocol on non-operative management, but the options are physiotherapy, steroid, or PRP injection. Let's talk about the surgery options. Originally, double incision was done with transosseous suture fixation of the tendon with no use of implant. Later, single incision has been developed with the development of the new implant. The advantage of the double incision is that tendon was reinserted at anatomical footprint at a radial tuberosity, and there is less risk of nerve injury. The main major possible complication is the heterotrophic ossificans. And a single incision has the opposite benefits and disadvantage. Multiple fixation methods have been proposed since the transosseous suture technique described by More. Initial fixation strengths allowed early active motion and loading. This believed to improve outcome. Choices for the tendon fixation are suture anchor, interference screw, endo button, and single custom intramedullary button. What about in chronic complete tear? There's a study that who got surgically treated at least 6 weeks after the injury without tendon graft, even though half of them result with complications, but the results show excellent patient-reported outcome measures and elbow range of motion. Reconstruction is considered when the stump is less than 2 centimeters, and these are tendon grafts that can be used. What about isolated bundle rupture? This is uncommon. If it happens, you might see an asymmetry of biceps, muscle belly, and can be evaluated by FABS view MRI. Radial tuberosity impingement. There is still a lack of evidence on diagnosing and describing these symptoms. During pronation, the rotating radial tuberosity makes the radial ulnar canal narrower, and this is believed that the hypertrophy of the radial tuberosity can lead to the radial tuberosity impingement, and so can become a predisposing factor of the distal biceps pathology. Now let's move on to the distal biceps. These are the risk factors of the distal triceps tear. There was a recent cadaveric study describing the distal triceps insertion on the olecranon and correlates the finding those seen in normal MRI anatomy of the triceps insertion. All specimens show that the tendon is with 3 distinct insertional areas in the olecranon, which are capsular layer, deep muscular layer, and superficial tendinous layer. The distal tear usually occurs as the detachment of this tendinous layer of the bone. The tear can be caused by direct elbow trauma, exercise, or overuse. Usually come with a presentation of sensation of tearing or popping, loss of elbow extension strength, or maybe swelling or ecchymosis on the posterior aspect of elbow. In plain film, we look for enthysophytes at the tip of olecranon and flake sign, which is the triceps avulsion fracture. MRI and ultrasound can be used to distinguish between partial and complete tendon injuries. There has been no consensus on management of the partial tears regarding to the percentage of the tear of the superficial tendinous layer. But however, many people choose conservative treatment in those who can still perform active extension with good strength by immobilization and followed by progressive elbow flexion. If not better, then surgery might be needed. Primary repair can be done by open repair or endoscopic repair. In acute complete tear, early repair within 3 weeks is recommended, but can be as late as 8 months. But the main concept of the surgery is first, suture onto the triceps tendon, then second, the fixation, which can be done by transos suture anchor, knotless anchor, single or double row technique. Now talking about chronic complete tear, Achilles tendon allograft can be used. Hamstring augmentation can be used in poor quality tissue. Olecranon stress fracture usually happens after repetitive stress on bone causing abnormal remodeling process. Usually happen in baseball player. Excessive tensile forces of triceps on olecranon occur during acceleration phase of throwing. Patient would develop loss of terminal elbow extension. Baseball players usually show worse performance on pitch. There will be tenderness over the olecranon and pain during resisted elbow extension. These 2 peaks are the special tests. Typical findings in plain film can be seen if the stress fracture is big enough. Early detection within 3 weeks had earlier return to sport compared to later than 3 weeks. MRI is a gold standard for detecting stress fracture with high sensitivity and specificity. Management usually conservative first for 3 months, if not better than surgery. The difference between the spur and osteophyte is that spurs from at the area of triceps insertion and can be fractured during traction injury, while osteophytes forms along the articular margin and is the abutment of the olecranon and the glenoid fossa. Usually conservative first for 3 months and then proceed to surgery if not better. I want to emphasize that in removing the spur, tricep tendon was elevated to expose the spur. So make sure to repair the triceps tendon back to its insertion to stop the tear progression. And this is an example of the case with both spur and osteophytes. After performing the spur excision, you can see that the triceps was elevated. Oh, sorry, this one, elevated. So after that, we repair the triceps back to its insertion. Thank you for your attention.